I wanted to talk this morning about the paradigm, the change in treatment and the paradigm shift we've had in treatment of pediatric brain tumors. Granted, this also applies to adult, but I want to talk about how we've really changed the landscape of pediatric brain tumors by using molecular targets in immunotherapy. This has been something that has really come into play over the last 10 years. The earliest indication and investigation into molecular targets was really by a landmark paper by Mike Taylor back in 2012, and that led to the 2016 WHO classification of tumors. So in 2016, the World Health Organization classification of tumors, it's both conceptual and practical advance over its 2007 predecessor. For the first time here, the WHO classified CNS tumors based on molecular parameters in addition to histology to define many tumor entities, thus forming a concept for how CNS tumor diagnosis should be structured in the molecular area. As such, the 2016 WHO presents major restructuring. And specifically, it divides out things such as the Medulloblastoma subtyping, as well as more adult type tumors, such as the GBMs with IDH mutant, IDH wild type. So this has been something that has really helped tease out different entities within pediatric neurosurgery. We used to classify pretty much all molecular or embryonal brain tumors that we called them something called CNS peanuts. And so we noted that, and Strum et al. Noted in 2016 as well, that new brain tumor entities emerged from molecular classification of CNS peanuts, such that CNS peanuts were no longer referred as CNS peanuts, but specifically as separate entities. So what this did is Strum et al. Saw that there are about 534 CNS tumors that are institutional diagnosed as CNS peanuts, and based on new molecular tumor entities, genetic characterization, and DNA methylation profiles, 61% of the cases initially diagnosed as CNS peanuts were reclassified as other well-defined molecular entities. High-grade gliomas harboring different genetic alterations up to 31%, and embryonal tumors up to 18%, comprising medulloblastoma subtypes, a subtype of a tumor called ETMR, as well as ATRT. So this was a huge change and shift for us, but we didn't really know what that meant. We didn't know, even back in 2016, how this was going to affect treatment. And in the last 10 years since I've been in practice, I've seen quite a different shift in the way that we're treating patients. And it gives at least me hope that we can eventually try to treat these kids with these aggressive tumors a bit more effectively and reduce the systemic toxicity that they get from not only the chemotherapy as well as the radiation that they receive. So again, there's novel entities. We can go through this ad nauseum, but there's different molecular markers such as CNS high-grade neuroepithelial tumors with B-core alteration. We actually had a kid here from Argentina that we were told that it was a glioblastoma, and this kid had a B-core mutation, and she actually presented with pretty significant disease, and she had a significant tumor burden in her spine and presented with spinal cord compression and cauda equina syndrome. Dr. Raghu actually did a large laminectomy on her to try to save function. And now, based on the pathology that we got from that specific case, she's actually tumor-free, which is prior to this, just based on histopathology, this was deemed to be an untreatable high-grade tumor. So the message of the study really highlights that cases that were diagnosed as CNS peanuts in the past do not correspond to a single and homogeneous molecular entity. And as a result, CNS peanut really has been removed from recent updates, and we don't really refer to it as that anymore, but you'll see peanut in some talks here and there. So as we go through here, why does that matter? So we use this paradigm for treatment of medulloblastomas. So we referred to medulloblastoma, which is the most common aggressive posterior fossa tumor. And Mike Taylor had a beautiful presentation for us where he showed that there are 4 different distinct molecular subtypes. And now within those subtypes, he's noted that there's even more subtyping. I won't go into that as he's already discussed that. But prior to the subtyping, we really looked at medulloblastoma treatment as standard risk after surgery versus high risk, and then versus baby. So standard risk patients, these are patients who don't have metastases and don't have significant residual after surgical resection. They're treated with radiation as well as chemotherapy. And the 5-year event-free survival and overall survival is about 80 to 86%. And so this is pretty good. And so new strategies to reduce toxicity really has accrued over 540 patients. And this was to decrease the radiation dose and changing the chemotherapy. But again, it's not a one-size-fits-all type of picture here now that we're putting into play the different subtypes for medulloblastoma. So high-risk medulloblastoma, these are children who have significant tumor burden. They have spread to the spine, and they also or spread to the spine, or you have residual left in surgery. And so these children get a higher dosage of radiation, and they also get a chemotherapy as well. And I'm not going to go into the different COG protocols, but this is kind of a guide for us when we have kids that come in to see what we did before and what we do now. And this is something that I talk to the oncologists about, so we make decisions together about this. So again, we constantly try to new strategies to increase the efficacy, the COG protocols. They're trying to do different treatment options. And then you have the infant risk medulloblastoma, which is children who are under 3 years old, who you don't want to radiate, because we know the effects of radiation in children who are under 3 years old are significant. So we try to keep those children away from radiation. So here they have multi-agent chemotherapy followed by high-dose chemotherapy, stem cell transplant, versus multi-agent chemotherapy. And there's several Head Start 1 and 2 protocols. Now there's also 3 and 4. And in these kids, event-free survival is much poorer. So that's where this subtyping of medulloblastoma comes in. So that high risk, standard risk, and infant risk medulloblastoma, we still use that to some extent, but now we also try to look and see what the molecular subtypes of medulloblastoma each tumor is, and then try to apply the treatment paradigm to this as well. So there's specifically 4 different subtypes right now that we're using for treatment. We're not using the subspecialized subtypes within each subtype that Mike Taylor recently came out with. But we have the Wnt, sonic hedgehog, group 3 and group 4. We know that the Wnt subtype has a very good prognosis, and that we know that the group 3 subtype has a very poor prognosis. So what does that mean for us? We have traditionally, if you've had a group 3 child who's a baby, we treat them as the infant risk medulloblastoma, but if they are group 3, and there's a COG protocol for this, we are moving them ahead and radiating them before they hit over 3 years of age, because we know that this tumor recurs aggressively. In terms of the Wnt positive medulloblastoma, this has a really excellent prognosis. So when you look at the survival curves here, you can see that Wnt has much better survival than the sonic hedgehog group, then group 4, and then group 3. So uniformly, group 3 and group 4 don't fare as well, whereas the other 2 fare a bit better, but Wnt definitely the best. So what does that mean in terms of treatment and the shifting? So we're pretty much curing almost all Wnt positive patients. So what the goal is, and this is being studied right now, is to substitute the current therapy with a Wnt inhibitor, which is not quite yet available, and then use this prognostic marker and de-escalate therapy, like we've done with standard risk and high risk medulloblastoma. So right now, they're also doing a pilot study of surgery and chemotherapy only for children with Wnt positive medulloblastoma. And this is a huge paradigm shift, obviously, because as you saw from my prior slides, pretty much every child with a medulloblastoma was receiving craniospinal irradiation with a boost to the tumor margin. And so this is excellent if we can avoid the toxicity that the radiation will give to these kids over time, because although even if they are over 3 years old, it still has lasting effects, and radiation is not benign, as we've seen. So what have we learned? What we've learned from this is that it's really not a single disease. When I was in training, we treated every medulloblastoma the same. The treatment really needs to incorporate our molecular understanding of this disease. And while current treatments have good results, they're not good enough for some, and they're too toxic for most. And that's where siphoning out these different subtypes and going through these different clinical trials and COG protocols will really give us the answer. And hopefully we'll have those answers in the next 10 years. So the other tumor that we've really seen that has been problematic, specifically the pediatric population, is ependymoma. Unfortunately, we haven't gotten a handle on this tumor as well as we have with medulloblastoma. But this really represents about 170 cases per year in the United States. We saw about 6 patients last year with ependymoma. And the median age of diagnosis is anywhere from 51 to 71 months. I would say less than half are diagnosed with children less than 3 years, and 90% are intracranial in origin, and 2/3 arise in the posterior fossa. And unfortunately, in these kids, dissemination through spinal fluid is estimated to occur in about 15% of patients. So survival statistics are disappointing, with 5-year survival of 50 to 64% and progression-free survival of 23 to 45%. Recurrence is typically local, with a median time to recurrence of 13 to 25 months in these children. However, 20% of these failures have isolated distant recurrence. And so what we're noticing, and again, this is excellent work done by great leaders in the field, where they've looked at supratentorial ependymomas and infratentorial ependymomas, as well as spinal cord ependymomas. And they've subgrouped them into different molecular subgroups. What we mainly see here are those infratentorial ependymomas. And we notice that there's what we call an A group and a B group. And the A group has a poorer prognosis, and the B group has a better prognosis, and usually are found in older kids. Unfortunately, when I go back and look, since we started doing this molecular subtyping of ependymomas, we haven't had a single child that has had the B subgroup. And uniformly, I think with the exception of one child in the last 5 years, we've had a recurrence of the ependymoma, even if they were able to be gross totally resected. Now, the supratentorial ependymomas we've had a bit better luck with. So as of yet, we don't really have a handle on what these subtypes mean and appropriate treatment targets for them, but hopefully with time we'll be able to have a similar type of treatment paradigm and studies as we do with medulloblastoma right now. So what we've also seen is that we're trying to do these baby brain studies, and what they're called is the POG studies, where you give kids, instead of the radiation, you give them chemotherapy. And we've seen that even in those children with ependymoma, it's not really successful. So we're not really making strides with ependymoma, unfortunately. The single thing that is important in these children is that if we're able to obtain a gross total resection. If we're able to obtain a gross total resection, then the progression-free survival and overall survival is much higher than if you're not able to get a complete resection. And then this also lends itself to another discussion of, should our community physicians really be taking on these types of tumors if we're only seeing 170 of these a year in the United States? And if we don't have high volume centers doing these cases, then what we're doing is we're not necessarily giving these children the best outcomes, because we're not able to get it gross totally resected, and then they come for second look surgery, and at that point you're already behind the 8 ball. So the next study that's important to talk about, or the next tumor that's important to talk about, is diffuse intrinsic pontine glioma. And so this is an abysmal diagnosis. It's uniformly fatal. We've made 0 strides in this. There's been several trials, and unfortunately, we've only gathered more information, but we haven't necessarily been able to make any strides with overall survival and death rates in this tumor. So generally, the diagnosis of this has relied on imaging studies, since really the appearance is pathognomonic and surgical risk initially was felt to be high and unlikely to affect therapy. That is until we started to look at the molecular markers. So in Seattle in 2009 and 10, they started to biopsy every single DIPG, which was a different paradigm than what I had seen when I was in Utah in residency. So that led to really this prospective feasibility and safety assessment of surgical biopsy for patients with newly diagnosed DIPGs. This is a multi-center study. We were actually involved in this trial. And what it did is it allowed us to look at tissue and see if there were any molecular targets that we could find. So subjects were eligible based on clinical features and imaging appearance. 53 patients were enrolled at 23 institutions, and 50 underwent biopsy. There were no deaths directly attributed to the biopsy procedure, and 1 subject died 2 weeks following biopsy with the cause of mortality attributed to disease progression, and that was actually our patient here. So what they found based on this study was that there's really biologically distinct subgroups of DIPG. There's 3 major subtypes: H3.3 with P53, H3.1 mutant, H3 wild type. And there wasn't a single case of BRAF V600E mutations. And I'm not going to go into the BRAF mutations because that's more low-grade tumors, but a BRAF mutation is generally found in low-grade gliomas and tumors, and you can target that. So that was interesting finding. And the other thing that was found was this H3K27M mutation, which really has emerged as a prevalent genetic mutation in these aggressive midline gliomas that involve specific parts of the brain. This doesn't limit itself to just a DIPG, but it also extends to the thalamus, the pons, or the spinal cord. And so this, again, was categorized as any brain tumor that contains the H3K27M mutation as the highest grade, because it confers such a dismal prognosis. So what does that mean? That means that if you look at it under a microscope and histopathologically, it looks as if it is low grade. But if you have this mutation, then it automatically puts you to a grade 4. And beyond palliative radiation, no medical therapy really had been shown to provide clinical benefit for patients with this mutation in this tumor. And molecular targeting is really what we're trying to do here. So in those patients harboring the H3K27M mutations, they're found to have elevated expressions of DRD2, which is called dopamine receptor D2. So this is a dopamine receptor family, superfamily of G protein coupled receptors. And it's really dysregulated in many cancers, specifically upregulated in these midline high-grade glioma lesions. And so there's something called a DRD2 antagonist. And this is something that we've been involved with here. And it's through the Miami Cancer Institute. and our partners there, where there is a phase 1 clinical trial going on right now where they're using an antagonist of dopamine receptor D2, penetrates the blood-brain barrier, and it's supposed to induce tumor cell apoptosis. It's upregulated again in H3K27M lesions, and they've also found that DRD5 expression is decreased in these lesions. So we were involved in the phase 1. It's now in phase 2. That it's demonstrated safety, no adverse events, and it's been well tolerated. And the dosage was 625 milligrams in adults, and it's lower in children. In this trial, there were 6 pediatric patients that were treated. Only 2 out of the 6 had major symptom improvement. We had one of our patients out of the 2, and then we had another patient enrolled through an IRB approved compassionate use protocol. And then this requires an MRI every 2 months. So what we saw is that we did have slightly longer progression-free survival in these children, but they still overall did not survive the disease. So this really provided an early proof of concept for this novel agent. And so right now we're involved in this clinical trial for pediatric patients. And what we're doing is we're using this concomitantly with radiation therapy. And so we'll see how that goes. So the next thing I wanted to talk about, which I think is one of the most exciting things in terms of using molecular targets and immunotherapy together. So for years, the foundation of cancer treatment really, as I've discussed here, surgery, chemotherapy, radiation therapy. But over the last 2 decades, targeted therapies such as Gleevec and Herceptin, that are drugs that target cancer cells by honing in on specific molecular changes seen primarily in those cells, have also cemented themselves as the standards treatments for many cancers. Over the last several years, immunotherapy is being used, and what we're trying to do is see CAR T cells, so engineering patients' immune cells to treat cancer. So this is a rapidly emerging immunotherapy approach. You can also call it adoptive cell transfer. But what it does is it collects and uses the patient's own immune cells to treat their cancer. There are several types of adoptive cell transfer, but we're going to talk about the CAR T cell therapy. So as the name implies, CAR T cell therapy uses your T cells, which are often called the workhorse of the immune system because of their critical role in orchestrating the immune system and killing cells infected by pathogens. So the therapy requires drawing blood from patients and separating out the T cells. Next, using a disarmed virus, the T cells are then genetically engineered to produce receptors on their surface called chimeric antigen receptors, or CARs. Once the collected T cells have been engineered to express the antigen-specific CAR, they're expanded in the laboratory into the hundreds of millions, and the final step is the infusion of the CAR T cell into the patient, which is also preceded by a lymphodepleting chemotherapy regimen. So by no means is this significantly less toxic. So if all goes as planned, the engineered cells further multiply in the patient, and with guidance from the engineered receptor, target the molecular marker that you're targeting, that you genetically engineered the CAR T cells for. So right now, there's FDA approval for this in acute lymphoblastic leukemia in children, and there's also an FDA approval in a leukemia on the adult side. So what they noticed, Mount et al. Noted that there's a potent anti-tumor efficacy of anti-GD2 CAR T cells in these H3K27M diffuse midline gliomas. And so what they used was this chimeric antigen receptor expressing T cells. And patient-derived H3K27M mutant glioma cell cultures exhibited uniform expression of these GD2 cells. So what they saw was these anti-GD2 CAR T cells systemically administered to diffuse midline gliomas had a significant survival percentage, as you can see by the line in blue, versus the CD19 CAR T cells. So this was very encouraging in the xenograft models that they looked at. So where have we taken that? And so now there's a couple of clinical trials, and you can go on clinicaltrials.gov, and we do this often for our patients where we try to see what clinical trials there are available. Hopefully we'll start to be able to offer more clinical trials than we are right now. But one of the clinical trials that's being offered is GD2 CAR T cells in diffuse DIPG and spinal diffuse midline gliomas. This is a phase 1 study, so it's only a safety study. And we're using these CAR T cells in those patients, and hopefully we'll see what the overall outcome is from just a phase 1 trial, and hopefully that'll move on to a phase 2 trial and then to a phase 3 trial. Now, there's also another clinical trial where they have T cells expressing HER2-specific chimeric antigen receptors for patients with HER2-positive CNS tumors. So what we've seen is in a lot of these recurrent malignant tumors, including ependymoma, medulloblastoma, some ATRTs, they have HER2 positivity. And so there's clinical trials right now looking at mainly recurrent and refractory tumors and injecting these CAR T cells. And these CAR T cells also can be injected intrathecally as well. And so all of these are just in the beginning stages and it's infancy of phase 1. So we don't really know what the safety profile is. We do know that systemically with the ALL trials that have now been FDA approved, they can have a significant cytokine response after injection of this. So they can have very high fevers, low blood pressure, and require intensive care unit stays, which is obviously also concerning with these children. So there's another study as well, a HER2-specific CAR T cell with local regional immunotherapy for HER2-positive recurrent refractory pediatric CNS tumors. And this expands, this is out of Seattle, and this is a phase 1 trial as well that expands the use of this to not just a few diagnoses, but several central nervous system tumors. So we're actually trying to see if one of our patients would be a candidate for this and see if we can treat them. I think one of the hardest things that we're dealing with here with our kids is that even if you do get a gross total resection, they're in their honeymoon period and they're clear of tumor for a while, and then the tumor comes back, and due to either Li-Fraumeni status or some sort of other caveat with their underlying pathology, they're not really eligible for many trials. So that's all I have for you guys today. I think I spoke a little fast. Do you guys have any questions for me?
Hey, Tova, it's Alan. The only question I had was, I know that we have great humanized HER2 antibodies, and it's been incredibly successful for, breast cancer patients, and it's been around for 20 plus years. I just didn't know the sort of the evidence for its efficacy in the tumors that you were describing. Is it just that the immunostain for the antibody on the tumor surface, or is there more data to support its efficacy in killing those types of tumor cells?
So all of these studies have had to have some sort of xenograft model, like I showed with the GD2 cell. So there has to be some sort of xenograft model that shows efficacy and decrease with some sort of survival paradigm before they would allow it to progress to a phase 1 study. So that's what they've done here. So there have been xenograft models that have shown that there's been some efficacy within the central nervous system tumors. And that's how now it's actually, I think there's 3 different sites that have clinical trials open right now for the HER2 specific CAR T cell. So it's Seattle, I'm going to say Stanford has one as well, a couple of other places. But each place has, the Seattle one has the most broad spectrum and umbrella for the different CNS tumors.
Any comments from our pediatric neurosurgery colleagues?
Yeah, good morning, it's John Raggett. Thanks, Toby. That was a nice review. Tell us what you see on the horizon for biopsy. I know we've talked in the past about these idea of doing getting a diagnosis without getting tissue, either from serum or CSF. Maybe it'd be interesting to hear your perspective on that and share it with the group.
Sure. So there's something called liquid biopsy that is specifically looking at BRAF mutations, which are typically found in the low-grade glioma population, as well as H3K27M. So these are all just experimental right now. So there is in Europe, there's a laboratory that's doing this, as well as up in Children's National. It's strictly for study purposes. We're not using it for any sort of diagnostic purposes right now, but it actually is very exciting because if we can use a liquid biopsy and get an answer of an H3K27M, then you wouldn't have to put a child through a biopsy of the pons, which obviously, although we can all do a stereotactic biopsy of the pons, there's always a risk of causing a worsened outcome for this child who already is not going to survive very long. So I do hope that in addition to these CAR T cells and the other molecular markers, that we could use the liquid biopsies and see how we can use that instead of doing biopsies, especially in these kids with deep-seated lesions where the risk of biopsy is higher.
I completely agree. It's Heather McRae. I just actually reviewed a paper a week or so ago with another group that was looking at trying to do LPs and using CSF. And I think I completely agree. We're not there yet, but hopefully we're headed there soon. I sent 2 patient CSF samples over the last couple of years to the group in DC that's doing it. And both times for H3K27M, it correlated with the biopsy sample. We sent it just to see if it was working. So one was positive, one was negative, and that fit with the biopsy. But both of those were from EVDs, and I think the likelihood of yield is much higher if you're getting it from CSF in an EVD than in an LP. But hopefully someday. Great talk.
Dr. Niazi, sorry, I had a quick question, Ashish here. We had a few patients, at least on the cranial surface, who have these hypothalamic optic nerve, like pilocytic astrocytomas, that I'm sure they had, maybe as children. And I'm just kind of curious what the management is, in the pediatric world, for these lesions that look like they're intrinsic to the hypothalamus and, they're causing hydrocephalus.
Sure.
So, I mean, what's the role of maximal safe resection in these patients versus, getting like BRAF inhibitors involved?
Sure. That's actually a great question. I thought I was going to run out of time, so I didn't go over the low-grade gliomas, but specifically with hypothalamic optic pathway lesions, I think you need to tease out the patients who have a neurofibromatosis from those that don't. I think that's a really important distinction to make. And I think that the mistake in these kids is to try to get a gross total resection because we have seen, and there's several of Dr. Ragged's patients that are several years out now that I've seen amazing results on. I think first and foremost, treating the hydrocephalus is very important. I think if you can get a tissue diagnosis and be able to send some sort of molecular markers specifically for BRAF V600E, I think that's important as well. But I think the mistake is to try to get a gross total resection and leave these children devastated from a hypothalamic standpoint. And what I've seen, and even before the molecular targeting, is that these children have an excellent response to chemotherapy. And obviously in the patients with NF, you try to avoid any radiation. And obviously in children, we try to avoid radiation, but eventually that would be the next step if the oral or systemic therapy fails. But now with the BRAF markers, those are really good treatment modality as well. So I think the most important takeaway from those patients is that we really shouldn't be trying to obtain a gross total resection because the therapies work well. Dr. Raghav, do you have anything to say? I know you've seen these kids over 20 years time.
Yeah, I think the hypothalamic optic pathway lesions are a unique subset of tumors that where in general less surgical treatment is better. And although it's hard for us surgeons to accept that, it's true. There's a great deal of data from the ophthalmology literature. Granted, it's retrospective historical data that looks at visual outcomes in children with NF presenting with optic pathway lesions. And as you predict, if those children who have never had an operation have better vision, they also have better survival, but those are obviously the less aggressive tumors. It also reminds me that I believe Dr. Levy was traumatized many years ago by an optic pathway lesion that they showed him in his oral board exam. I'm sure he could describe the details of it because I believe he recommended open surgery for that. Alan, can he tell us what he did in that case? It was.
Yeah, I mean, it was actually, it was pretty hilarious, but, you know, with all the nerve wracking of an ABNF exam, but it actually was a tectal glioma. And you would have thought that if I had trained at sick kids, I would have done better, but I was presented that case with hydrocephalus, and they asked me what I would do, and I started to operate on it. And there were several calls from the waiting room from a distraught mother asking me how the surgery was going. And then I finally pivoted in the correct direction and recommended a shunt. I'm sure the case might have been done differently now, but yes, it scarred me big time.
Yeah, so it's striking how those things stay with us. I can tell you that you're in good company, Alan, but based on the responses from our residents last night in the mock orals, everybody needs remedial pediatric neurosurgery, not just you. Thank you.
That was a great talk, Toba. And Dr. Levy, I don't think you're the only one. This is Shelley speaking. I don't think you're the only one who recommended surgery for that case, because I also heard similar stories from other people, from the people at Sick Kids. So definitely, as Dr. Raghav said, in good company.
Is there any other questions? I don't know if Jay Lee is on the line, who's our next speaker from the Miami project.
Yes, since we have a couple minutes and we're on the topic of tumors, and I raised the question, this is Raghav again, I raised the question of liquid biopsy. You know, I was actually contacted recently by that Scandinavian group that's doing the liquid biopsy work, asking about pediatric focused ultrasound. You know, focused ultrasound therapy that we have a small pilot trial going for ablation at lower energy levels can disrupt the blood-brain barrier. And I know exactly where they're going with this. It'll enhance access to molecules that may be in the interstitial space and probably improve their ability to make a diagnosis with liquid biopsy. So that probably explains why the people at Children's National Medical Center in Washington and the Scandinavians are so interested in focused ultrasound. So I think there's an opportunity for both the oncology group here and the adult group, hopefully now to collaborate and see if we can't come up with a way to use our unit to do that kind of work. And I'm happy to talk to, Dr. Ivan or Komatar about that kind of stuff. But I think it's a pretty exciting idea.
Yeah, no, I mean, we would be very interested in that. I mean, I think that's a great venue to use that tool. So we could talk offline.
Absolutely. I'm supposed to have a conference call with these people soon. Maybe you, Mike, and Toba can be involved in that to discuss the opportunity.
Yeah, for sure. That'd be awesome. Toba, one more question for you. Obviously there's other people in the country that are very aggressive with different kinds of pediatric brainstem gliomas, and I'm only going to bring this up because we had Charlie Teo on the symposium, our brain tumor symposium the other week, and he was kind of talking about brainstem gliomas and the difference between diffuse and well circumscribed, and how there may be a role for surgery in more well circumscribed brainstem gliomas. Obviously I don't see a lot of those. I didn't know if you had any comments on that idea.
Sure.
The difference between diffuse and well circumscribed.
Sure. So I think that there is a use to it. And I think that it has to be the right patient. That's the most important thing. And it has to be in the right hands. So I know that Teo, as well as Rick Boop, they both have extensive experience in it, and they definitely go after lesions that others wouldn't go after. I think the most important thing to tease out here is to make sure that we're diagnosing these diffuse intrinsic midline high-grade gliomas from the more low-grade lesions. And so that's the differentiation that needs to occur. So generally, the more well-circumscribed lesions and the brainstem are low-grade, and whereas the diffuse lesions are more high-grade. And so it's really important to tease that out. And I think if there is a safe avenue to get it out, then we can definitely attempt to do so. But you don't want to do it at the detriment of the patient. And in essence, there's a saying that you don't want to have a clean scan in a devastated patient. So I think we need to put it into perspective as to what are our goals of surgery, and can we do this safely without leaving these patients devastated? Because nobody wants a devastated child that's going to need, or an adult for that matter, but these children will need lifelong care. And so I think that's the really important take-home point of this, is that we choose the patients appropriately, be humble enough to know when to stop, and humble enough to know that this can't be done safely, or it can be done safely.
And the mutational workup of those two different types of tumors should be also drastically different, and that would help you with that.
Correct.
If you did have a biopsy, right? Yeah.
Correct. So, for example, I biopsied a kid who looked like it was a more well-circumscribed lesion, and it turned out to be an H3K27M lesion. And then there was a patient of Dr. Bhatia's that was a brainstem lesion that he biopsied, and that was found to be a low-grade tumor with a BRAF mutation, and he went ahead and resected whatever he could safely of that lesion, left the patient neurologically intact, and then that patient went on to get a BRAF B600E medication and is on maintenance therapy right now and is doing very well.
So this is John Raggett again. That's a great example, Mike, of where being able to make an immediate diagnosis at the molecular level would have a significant effect on our surgical strategy. And with all due respect to Dr. Teo, I think most of those tumors cannot be resected completely. We're not all him, and to leave a residual only to find out that it's a lesion that's susceptible to targeted therapy and risk injuring the child because you feel the need to get a gross total resection, that could be avoided potentially. But we have to enhance our ability to make an immediate diagnosis that would then let us apply a targeted treatment. So, you know, I think that's a really, really important question, because if we can make the diagnosis and it's at less risk and have a chance of cure using a targeted treatment, we could avoid a great deal of the morbidity associated with taking out those brainstem lesions. And that intramedullary tumor that we showed in M&M last week that I'm scarred by forever, that's another example.
Yeah, thanks for highlighting those points. I think it's a very complex problem, and it's not just you know, that TCAR cells are going to be the solution for everything. It's always going to be some role of surgery, some role of mutation, and a very complex solution with the family. But yeah, great talk, Tova. Thanks so much.
Thank
Thanks
you.
very much. Thanks, Tova.
Are we ready, Alan?
Yeah, yes, we are. Thank you, Dr. Dietrich.
Oh, well, thank you. Good morning, everyone. Fantastic talk. Today, it's my pleasure to introduce Dr. Jay Lee. Dr. Lee is a associate professor in the Department of Neurological Surgery and a very important component of our MAMI project scientific community. He's been working for many years on trying to study the glial scar, and has really led to rewriting the textbooks in terms of the role of other types of cells in forming that particular scar. And it remains a controversial area. You know, if the astrocytic scar, the fibrotic scar is a good or bad or indifferent to regeneration and repair. So today, Dr. Lee is going to kind of talk about some of his research that's using cutting edge strategies, including single cell sequencing, to actually do a deep dive in terms of the inflammatory responses and how it can affect the healing of the spinal cord. Jay, good morning. Thank you for joining us.
Good morning. Thank you for the kind invitation. Let me try to see if I can share my screen. Here. Okay, then put this in presentation mode. Hopefully you guys can see that.
Yes, we can see it.
Okay, great. All right, thank you. Again, thank you for the kind invitation. And so it's always a unique opportunity to present at Neurosurgery Grand Rounds. It's quite different from regular scientific talks that I'm used to presenting at. So rather than overloading you with data, I wanted to first start out with kind of giving you my thoughts on what this quote unquote the scar is. And as you can tell from the title, I prefer not to call it a scar, but rather a wound healing process. And I'll explain that in a little bit. And obviously, as clinicians, you're probably wondering how we can use this basic science information for therapeutic purposes. And I'll certainly touch on that a little bit, but I will certainly end up going into a bit more detail about some of the more basic science research that we have been doing. Again, in hopes of kind of opening everyone's eyes to subjects that you guys may have not have been kind of aware of or thought about, and kind of try to provide a unique perspective on our thoughts and on how we're targeting spinal cord injury science, pathobiology. So I want to start out with actually the most important slide, which is giving acknowledgments to the people who actually did the work. So, you know, I usually have a lab photo that's taken by Rob presented here, but the most recent photo is obviously on Zoom. And so these are the people that are currently in my lab, recently taken. and highlighting several people here. So a lot of the data that I'll be showing you today was done by former students and postdocs, but I'll be ending up presenting work on macrophages done by a current graduate student in the program, Christine, who I think is in the audience today. And I also want to highlight Dylan Carrington, who is actually the first recruit from Dr. Levy on the BLN scholarship program. So he's been with us the whole summer. He's been a fantastic addition, and we're certainly glad to have him. Okay. Also, I want to acknowledge some of my collaborators within the University of Miami. I collaborate a lot with Pontelise, Sulfas, Fanslam, and John Bixby. And some of the work that I won't be able to show you today on EAE, multiple sclerosis with Roberta. I'm close collaborator with Nagi Aya, looking at epigenetic inhibitors of inflammation. And we're also collaborating with Courtney Dumont on developing biomaterials that can actually promote wound healing. I have collaborators from other institutions who have contributed significantly to my work. And with that, I will get started. So the image in the back is background. It's just kind of a nice picture that I usually, one of my favorite pictures from my research is actually taken when I was a postdoc. That's still one of my favorite pictures. So I'm just using it as a background. It's not really meant to convey any scientific information. So probably most of you are familiar with the word scar, and the process of scar formation has really been a focus of spinal cord injury pathology and research for decades now. And the context in which we understand or investigate the scar has traditionally been in terms of inhibition of axon and tissue regeneration. And so the dogma has been that the scar tissue that forms around the injury site inhibits axon regeneration, as well as regeneration of other cells like oligodendrocytes, and that this is detrimental. And so this is what's embedded in all the review papers. So if you are somebody that's new to the field, for example, as a postdoc or a graduate student, and you're reading all these review papers on scar, this is kind of the dogma that's embedded into the brain of people who are new to the field. But a lot of things have changed. And the way I understand the scar is actually, I want to put it in the context of the processes that lead up to scar formation. Namely, it starts out with inflammation. It starts, minutes to hours after injury, and kind of lasts for a long time. And this inflammatory response gives rise to cell proliferation, and so this usually occurs days after injury. At least in the rodent models, it peaks at around 3 days after injury. And that's in response to all the inflammatory cytokines that are expressed by multiple cell types. And then this cell proliferation gives rise to tissue remodeling. And so there's extracellular matrix deposition, there's cellular replacement, hemostatic responses as far as the vascular goes. So there's a lot of things that occur during tissue remodeling, and this process occurs over years. And scar formation is kind of the end product, one of the end products of tissue remodeling and these processes that come before it. And if you look at these 3 steps over here, to clinicians, it's probably obvious that these are actually classic steps to the wound healing process. And so this is the context in which I try to approach spinal cord injury pathobiology. And so if we're trying to understand inhibition of axon regeneration and tissue regeneration, my belief is that it really has to be within the context, the framework of a wound healing response, and not just scar formation. And so if we mention the word scar, obviously it has negative connotation, and nobody really wants a scar. But if you kind of frame this in the context of wound healing, it certainly gives it a different connotation, different meaning. And I think most people would agree that wound healing is something that's beneficial and something that you would want and promote. Okay, so just to kind of put that in a schematic, this is a sagittal section of a spinal cord. Obviously, it's very heterogeneous. I don't have to go over this in detail with this audience. And so immediately after injury, there's inflammation, there's cell death, there's necrotic tissue, and the complex cytoarchitecture of the central nervous system now is made even more complex by infiltration of primarily leukocytes that come in from the blood. And so now you have all sorts of cell types that are now interacting with each other during this wound healing response. Inflammation gives rise to cell proliferation, and so now you have replacement of certain cell types, mostly glia and immune cells that now start to fill up the lesions. And then this gives rise to tissue remodeling. And the end product, as I mentioned before, is really two types of scars. The classic scar that most neuroscientists have been studying is a scar called the glial scar. And this is comprised, as the name implies, mostly glial cells. The fibrotic scar is something that we've been kind of focusing on the last 10 years or so. And it's really understudied compared to the glial scar. And in fact, when I was a graduate student, I was told that there is really no fibrotic scar that's present at the injury site, or very minimal at least. But we're trying to change the narrative on that, as I'll show you a little bit later on. And as far as the cellular composition goes, so the glial scars, it's really kind of cool how the injury site forms here. Glia likes to stick with glia and other neural cells. Non-neural cells like to stick with each other. This is not true for all types of CNS injury, but for spinal cord injury, this seems to be the case. So in the glial scar, most of us are familiar with the astroglial scar. In fact, the two terms have been synonymous for a long time. But now we understand that the glial scar is comprised of other glial cell types as well, such as microglia, even oligodendrocyte progenitor cells. And the obviously hematologous macrophages are not glial scars, but they are present here. The fibrotic scar is actually all the non-neural cells. So all the foreign cells that are invading the spinal cord are comprised of fibrotic scar. And over time, it's really comprised of two main cell types. One is fibroblasts, and the other is hematologous macrophages. And so these two processes occur in parallel. The glial scar forms in response to a central nervous system injury. Remember, the main function of glia is to maintain homeostasis. And so in response to injury, that's kind of what they're doing. They're trying to maintain a homeostatic environment, both chemically and physically. Physically in a sense that they actually physically try to wall off this injury site to prevent the spread of these infiltrating foreign cells. The fibroblasts and the macrophages, so I'm just going to call them macrophages from now on. So it's implied to be different from microglia. So these two cells, they come into the injury site. Obviously, normally they're kept out mostly by the blood-brain barrier. But when you have a rupture, physical rupture, such as in spinal cord injury, there's really no way to prevent them from coming in. So the monocytes come in, differentiate into macrophages, they attract fibroblasts, and now they form this lesion. These cells are actually undergoing a wound healing process, very similar to a wound healing process that you would encounter in response to injuries in peripheral organs, so such as fibrosis of the liver, skin, heart, kidney. These cells are also coming in with good intentions. They detect an injury, and it's their job. So it's the job of macrophages to hone into the injury site and try to phagocytose the debris that's there. That's their job. And so they don't know that they are not supposed to really be in the central nervous system. And so these two processes occur in parallel. And so this is kind of the focus of my research. How do these processes occur? What are the molecular mechanisms? And and kind of what's the effect on spinal cord pathobiology and how can we target it for therapeutic purposes. So now if we go into tissue sections, a lot of work is based on mice, just because they're genetically tractable animals, and we can really go into mechanistic studies. And so these are sagittal sections of the mouse spinal cord after a mid-thoracic contusive spinal cord injury. On the left here, you see the glial scar in green. So that's marked with GFAP for astrocytes. As you can see, there is there's a GFAP negative region, and that negative region really corresponds to the fibrotic scar. Traditionally, the field has used kind of surrogate markers for this, such as fibronectin, and you can see that they form very complementary regions. But the pathology here, as you might notice as clinicians, is kind of different from what you might encounter in humans. Rats are actually a better kind of mimic the human pathology in that they develop a fluid-filled cyst, a cystic cavity. But as you can see here, even in the rats, you see a fibrotic scar in red that's marked by PDGF receptor beta, and then in white is the glial scar marked by GFAP. So just to kind of give you a brief overview of this fibrotic scar, which many of you may not be familiar with. So the question is, we have this contusive injury. So theoretically, the dura is mostly maintained and is intact. There are really no fibroblasts in the central nervous system that we know of. So then how do we get this fibrotic scar? Where are the fibroblasts coming from? And so we found that, in fact, if you look at a transgenic mouse in which fibroblasts are labeled with GFP, and you look at the spinal cord, these green fibroblasts labeled with green fluorescent protein here, they align the large vessel, large diameter vessels as they enter and leave the spinal cord. And so this is and the red here is labeling all the vasculature in the spinal cord. So as you can see, this is where the fibroblasts reside. So these are perivascular fibroblasts. And now if you take these mice and you injure them, you can see that the fibroblasts come in over time. They take several days to actually now start accumulating at the injury site, and then they persist for a long time. They persist as long as we've been able to look at them chronically. So this is now up to 8 weeks now. And again, they are surrounded by the glial scar, as I showed you in the diagram before. And then the image on the right here, you can see that the fibroblasts that are lining the vasculature labeled in red are delaminating and peeling off the vasculature and proliferating and migrating toward the injury site. And that's the source of the fibrotic scar. We've shown this now, not just in spinal cord injury, but also in EAE model of multiple sclerosis. And so you can see that these green fibrotic regions, they overlap with demyelinated regions after EAE very well. And even after stroke, we can see the fibrotic region forms. So it seems to occur in pathologies where neuroinflammation is very prominent. I don't expect that it'll occur in all CNS diseases. So for example, like Alzheimer's and Parkinson's, we haven't checked, but my guess would be that it wouldn't be that prominent there. But certainly in pathologies where neuroinflammation is prominent, I would expect that at some point you'll get a fibrotic scar. And so the question is, what happens when you ablate the scar? And so certainly if the dogma has been that the scar is detrimental and so you want to get rid of it, which certainly has been the approach for a long, long time, then you would expect that ablating the scar would have beneficial consequences. So 8 years ago, I think, about 8 years ago, when I first gave my neurosurgery grand rounds as a new recruit at the Miami project, toward the end of my talk, Dr. Levy asked me a question. The question was, what would I expect if you use irradiation as a kind of a therapy to reduce the scar after spinal cord injury? And my response was, I want to give that a little bit more thought, and I'll get back to him a little bit later. Well, I've thought about it for about 8 years now. And so I think I'm finally prepared to give you an answer, Dr. Levy. So hopefully, I won't give it to you now, but hopefully toward the end of the talk, you'll have, all of you will have a better impression of what that might result in. So the astroglial scar, and so this is kind of the power of mouse genetics. It really allows the investigator to test these really mechanistic hypotheses that otherwise we wouldn't be really able to test in a rat model. And so the first component of the scar that was ablated was done, I guess it's been about 16 years now, was done in the lab of Michael Safronov at UCLA. And so he took these mice in which you can ablate astrocytes, but in particular, not all astrocytes, because that would obviously be bad, but more specifically, proliferating astrocytes. And so astrocytes don't proliferate a lot in healthy tissue, but in response to injury, they certainly do. And so the kind of the genetic trick that they used here is to ablate proliferating astrocytes. And obviously, and those would be in response to spinal cord injury. And as you can see from the title, reactive astrocytes protect tissue, preserve function, you can kind of get at the answer for this question. So on the left here, on the left column, you have wild type animals. And so this was more of a proof of concept. So they used just a kind of stab wound in the spinal cord to cause a small lesion. And so when they do this lesion, you can see that over time, it kind of closes up pretty well. You can see that the glial scar forms. Here is another crescent violet stain of a horizontal section of this surgical lesion. You see that the lesion has formed here. And then on the bottom is a three-dimensional reconstruction of the actual lesion site shown in red. So if you ablate these proliferating fibroblasts in these mutant mice, you can see that the lesion actually becomes much bigger. You actually fail to have a clear delineation of where the lesion ends and begins because the glial scar actually fails to form a barrier around the injury site. And the leukocytes now kind of spread all over the place and cause more damage. This image doesn't have the leukocytes here, but it's in the paper if you're interested. And now the lesion size becomes much bigger, as you can tell by the size and volume of this region in red. So that was actually the first indication that the glial response plays a protective role. And that actually started to change the narrative on the function of the glial scar. And there's been more evidence from his lab about how the glial scar actually may promote instead of inhibiting regeneration. That's been a very controversial but interesting topic in the field. So now that we realize that there are more components to the glial scar other than just astrocytes, so what if we ablate those? More recently, in the lab of Steve O'Craw, he ablated microglia. And so this was a paper recently in 2019. And so now we have pharmacological tools where we can ablate microglia. And so this wasn't a genetic manipulation. Actually, this was a pharmacological way of depleting microglia in the central nervous system. And so when you give this pharmacological agent that ablates microglia, you can tell by the size of the regions that are encased in yellow here. Again, the lesion size actually gets bigger. And as you can see from the title, they're an essential component of the neuroprotective scar. So here's another one, another component of the glial scar that we believe plays a neuroprotective role. And how about the fibrotic scar? And so we haven't been able to do this, but other labs have. And so if you completely get rid of the fibrotic scar, again, using genetic manipulations, these are mice in which you prevent the proliferation of activated fibroblasts. And so if you do that, you get this cystic cavity here, and you start to lose tissue integrity. And the paper shows that the histopathology and the functional recovery of these animals actually worsen. It's been corroborated by an independent laboratory, and so using a different genetic mouse line. And so here, so this is now actually so on the left was a surgical lesion, but on the right here, this is actually a contusive injury. And so if you prevent the fibrotic scar from forming, in this case, the fibrotic scar being labeled PDGF receptor beta, it's very obvious, it's very prominent in the wild type animal. But once you ablate this, you can see by these kind of holes over here that, again, you start to lose tissue integrity. This tissue starts to kind of fall apart, and the pathology becomes worse, and the functional recovery starts to become worse. So you kind of now start to see a pattern here. The only component of the injury site, where the cellular component, where you ablate and it starts to show actually beneficial effects, has been the hematogenous macrophages. And so this was addressed now this is now over 20 years ago by Phil Popovich. And so he was the first to actually use immunological tools, in this case, clogenate encased liposomes, which is a classic immunological tool to deplete macrophages. And so when he did that in a model of spinal cord injury, he found that it promotes hyaline recovery and repair. And several labs after that have actually validated and corroborated these observations. We've more recently approached this from what happens then to the fibrotic scar if you do this. And we found that it actually reduces and attenuates fibrotic scar formation. And if you attenuate this, it actually has beneficial effects. I just showed you a slide where if you completely get rid of it, it's detrimental. But if you attenuate it by depleting macrophages, this is associated with more beneficial effects. So you can see from here, the top row in red are the hematogenous infiltrating macrophages that you see in red. And then in green are the fibroblasts that are coming in, labeled in this transgenic mouse. And if you treat these animals with clogenate liposome, there's a significant reduction in the infiltrating macrophages, as you can see from the reduced red here. And now this is associated with a significant reduction in the fibrotic scar. So typically, the fibrotic and the astroglial scar are kind of juxtaposed next to each other. You rarely, if ever, see these empty regions where fibroblasts are not really opposing the glial scar. But you start to now see that when you ablate or deplete macrophages. And the effect that it has on pathology is beneficial. So if you stain for neurofilament, there are a lot more neurofilament positive axons in clogenate liposome treated animals, as you can see in red here, as compared to control animals. And the lesion size does get smaller. So the lesion size is quantified here on the right. So lesion size is smaller in clogenate treated animals. And then just to show that, just kind of to test whether this is a neuroprotective or regenerative effect, we show that the number of neurofilament positive axons are pretty similar at earlier time points, but then it's greater at later on, indicating that this was probably not a neuroprotective effect, but rather a regenerative response in response to the macrophage depletion. In our hands, this didn't lead to a functional recovery. And in fact, the original paper from Phil Popovich's lab, they observed recovery when they looked at the BBB subscore, but the main score was not different. So there's different observations from different labs, but Some labs conclude that there are behavioral recovery, some labs don't, but I think most would agree that even the behavioral recovery that labs see tends to be very mild. And so obviously that in itself, we don't think is going to be a dramatic therapeutic, have a dramatic therapeutic potential. And so kind of the conclusion from these studies is that the therapeutic strategy of targeting the scar is really not to ablate the scar, but rather attenuate it through promoting a more optimal wound healing response. And this is kind of the approach that we're using in our lab. And this is our overall hypothesis as to how we want to approach this from a therapeutic standpoint. But the question is, how do we do this, right? And so for this question, we kind of have to understand some of the differences between these injury models. So this is now getting a little bit specialized, but I think to the audience here, you'll understand what I'm trying to get at and appreciate what I'm trying to say. So if we want to use this for therapeutic purposes, obviously we have to have an understanding of the pathology, the clinically relevant pathology. And we use mice, obviously for mechanistic purposes, but the rats are a bit different. They form the cystic cavities, that we think is detrimental to recovery. And so if you look at this or think about this pathology in the context of wound healing, they're really at the opposite ends of the wound healing spectrum, right? On one end, we have a very fibrotic response, and so that could be considered as an overhealing response that we often observe in mice. In rats, we have this cystic cavity that forms, and so this can be considered as an open wound that has actually never healed properly. And so this is an underhealing response, and so this is an open wound and a cavitation, right? And so this is kind of at the opposite ends of the wound healing spectrum. And obviously, at the middle is where you want to be. This is kind of the sweet spot, right? You want a proper wound healing response that actually promotes regeneration of functional tissue. And so if you want to get to this middle region, and from the perspective of the mouse model, you obviously want to reduce and attenuate the fibrotic and the glial response so that you kind of get to a more regenerative environment, as I showed you in the previous slides. But if you're now dealing with this open wound and cystic cavities that represents an underhealing response, then logically speaking, you would actually want to promote, I don't want to say scarring, but rather wound healing. So now you bring this more closer to what a mouse looks like. And so in this case, now you want to actually promote better wound healing. And now we're trying to use what we've learned from the mouse pathobiology and try to see if we can use that information to treat a more clinically relevant model in the rats. And so to kind of demonstrate how we're approaching this and kind of give you some supporting evidence of this idea, I've been collaborating with a close friend. His name is Pyong Kim. He has a lab in Korea. His interest has been stem cell transplantation into the spinal cord injury site for a long time. And to do this, he's been using various biomaterials to promote cell survival. And he's been using a lot of different biomaterials over time. And kind of he actually stumbled upon this particular biomaterial that has a reverse gel salt property. So it's actually a liquid, a fluid at room temperature, but then turns into a solid at body temperature. So you can handle it as an injectable biomaterial at room temperature, but then when you inject it into tissue, in this case spinal cord, the body temperature will now actually promote turning this viscous solution into a more gel-like hydrogel, and that kind of more closely resembles the stiffness of the spinal cord tissue. And so when he did this, he found that there was actually a much better preservation of the peripheral white matter that's often spared after contusive injury. But interestingly, this happened with a heavier deposition of extracellular matrix. In this case, it's denoted by fibronectin over here. So on the top, this is just a PBS injection into the injury site. The bottom is the injection of this hydrogel. And the hydrogel injected tissue, actually, the cavitation virtually disappeared. There was better improvement in behavioral recovery. And as I showed you on the panels on the left here, the histopathology got much better. And I won't show you all the data here just because this is published. And so what he found here was that this was dependent on the fibrotic response. And so if you eliminate this fibrotic response by injecting a high dose of Taxol, which is known to be an anti-fibrotic, so this beneficial effect disappears. You get the cavitation returns, and the tissue sparing is much less now. And this fibrotic response, since we knew that this was due to the infiltrating macrophages, if you limit the infiltrating macrophages, that again has a similar effect to ablating the fibrotic response. And so we think that this actually provides a lot of interesting ideas for us as far as how we can go about tackling this. Our approach now is not just use hydrogel alone, but to combine this with pharmacological, so with small molecules or biologics that we think is going to actually promote even a better wound healing response in hopes of promoting both axon and other tissue regeneration. So this is something that we're kind of trying to get off the ground in our lab. So, so the focal point really has been the role of macrophages in the wound healing response. And in our attempt to kind of better understand macrophage function, we wanted to get the transcriptomics of macrophages in response to spinal cord injury. So we thought that this would give us a lot, kind of an unbiased view of macrophage function after spinal cord injury. Obviously, there's a lot of literature on what macrophages do, but it's really kind of in the context of this M1, this outdated M1, M2 nomenclature, pro-inflammatory, anti-inflammatory macrophage. And so we just wanted to see kind of what else is out there in terms of macrophage function. And so we used a kind of a neat genetic trick tool. So to eliminate microglia in our data set, we generated bone marrow chimeras. And so I won't go into this into detail, but basically what you do is you take the polyribosomes here are tagged with hemagglutinin, and you do an immunoprecipitation, and then this tagged polyribosome is only expressed in infiltrating macrophages. And so then you can take an homogenate of injury site and do immunoprecipitation for polyribosome, which should now be specific to macrophages. And then you can extract RNA from the pulled down polyribosomes, and then you can do RNA sequencing to get macrophage specific transcriptomics. So this is published now, so I won't go into it in too much detail. I just wanted to kind of give you a glimpse of what led to the current project that we're working on. And so we compared 2 time points because we couldn't use uninjured tissue because there are no hematogenous macrophages in the uninjured spinal cord. And so we chose 2 time points, 3 days after injury and 7 days after injury. The reason being that 3 days is kind of when the monocytes start to differentiate into macrophages. And 7 day is kind of the peak of the macrophage accumulation at the injury site. And so we wanted to compare. So we took the RNA, so we compared the transcriptome of macrophages at 3 days and at 7 days. And we looked at the differentially expressed genes at these 2 time points. So the genes that are enriched in 3-day macrophages, if you take these list of, these are I think several thousand differentially expressed genes, and you put it into what's called a gene ontology, and what that will kind of spit back to you is all the biological processes that are kind of associated with the list of genes that you inputted. And so these are just biological processes and genes that have been annotated in the literature. And then the bar, so you see here, is kind of the p-value of these terms. And the kind of top terms that we came up with for genes that are enriched in 3-day macrophages are locomotor behavior. So this is not locomotion of the animal, but of the actual macrophages. Response to wound healing, cell adhesion, taxis, chemotaxis. So this was actually kind of, we were glad to see this. So basically these are representing the fact that macrophages and monocytes are migrating to the injury site during this time, which we know to be true. So we were glad that the data that we got was actually confirming a lot of the process that we knew should be happening at this time point. And so now we were interested in the 7-day macrophages, and what we expected to see were a lot of chemokines and cytokines that would be driving the inflammatory response. And kind of one of the goals that we wanted to address here was to look at how macrophages could be mediating the fibrotic response. And that's kind of one of the reasons that we were expecting to see, things like TGF-beta signaling, and then these pro-fibrotic and pro-inflammatory processes. But surprisingly, most of the processes that we saw pertain to lipid catabolism. So this was certainly not something on our radar. Certainly if you read review papers on macrophage response after central nervous system injury, whether it's stroke or spinal cord injury or multiple sclerosis, you're probably not going to see, or at least up until a few years ago, not see any review papers that emphasize the lipid catabolic response of macrophages. So this was certainly something that was interesting, but we were a bit puzzled because we're certainly not lipid biologists, and we didn't really know kind of where to go from here. And what we did was we took the transcriptomics of the 7-day macrophages, and we wanted to compare it to macrophages that have been already described in the field. And fortunately, macrophages are one of the most kind of well-characterized cells in the literature. And there are a lot of transcriptomic data sets that were publicly available that pertain to specific types of macrophages. And so I think these are about 19 or so different types of data sets that we use for comparison. And so now you can use bioinformatics to kind of really compare in an unbiased way. So now we're not going to cherry pick a few dozen genes, but we're going to actually take these several thousand genes and compare it to the several thousand genes that's been described for other types of macrophages. And what we found was that when you compare it to, for example, these quote unquote M1, M2 types of macrophages that's been studied in the field, our macrophages were most similar to macrophages that people have described as foamy macrophages, foam cells. So to neuroscientists, foam cells was something that was kind of foreign to us. But to clinicians, you are probably well aware of what foamy macrophages are. It's probably best characterized in atherosclerosis. And in fact, this was the study here was actually looking at foam cells in cardiovascular disease in terms of high-fat diet. And so our macrophages seem to be most similar to this cell type. which then kind of triggered a cascade of literature searches. And about 5 years ago, this was kind of the first paper to describe in a systematic fashion foamy macrophages after spinal cord injury. This is from Yiren's lab at Florida State. This is staining with all red O, which is a classic stain for neutral lipids to mark foamy cells. And so as you can see, these foamy macrophages, the accumulation of lipid droplets in macrophages really accumulates over time and persists for a long, long time. And so our data kind of confirmed this, the pathological observations that were made a few years back. And so now this kind of made us go down this rabbit hole of lipid metabolism and macrophages and how that could be affecting spinal cord injury pathology. So we've gotten a lot of help along the way from people who kind of know what they're doing. And so one of the things we wanted to do was develop an in vitro model for foamy macrophages that we could use for mechanistic studies. And so Christine Ryan is a talented graduate student in the lab, and she's been really spearheading this project with some help from James Choi, who's a research associate in the lab. And so she's been developing and using this in vitro model of foamy macrophages. And so traditionally how this was done was people would purify myelin and then add it to foamy macrophages, or add it to macrophages, and then they would become foamy in appearance, and then conclude from those studies that myelin is what makes macrophages into foamy macrophages. So as a person who's outside of the field, you kind of scratch your head and you think about what they just did. So they just added purified myelin, they turn into foamy macrophages, and then you conclude that the myelin makes them into foamy macrophages. Obviously, you added myelin, so of course the myelin is going to do it. If you add oxidized LDL, then oxidized LDL is going to make them into foamy macrophages. And so it just depends on your lipid source. And so we wanted to kind of address those types of questions here using this assay. And as you can see, so the approach that we took was we actually just homogenized the freshly dissected spinal cord with reasoning that this is more indicative of the environment that macrophages are going to encounter after spinal cord injury at the injury site. So it's a little dirtier, but it is, I think, more relevant. And it allows us to actually test the role of myelin, as I'll show you in a little bit. And so if you now treat these cells with the homogenized spinal cord, you can see that you start to see accumulation of these lipid droplets labeled in DIPG, I think here, or actually I think this is non-red. And this happens in a concentration dependent manner. So with more concentrated homogenate, spinal cord homogenate, you see an increase in lipid droplet accumulation intensity in the foamy macrophages. And so what effect does this have on macrophage function? So if you now treat this, so here is an assay for reactive oxygen species. We use a dye called Medulloblastoma. And so here, if you treat, this is just macrophages and media. Obviously, you're going to have some macrophages sporadically that are expressing reactive oxygen species. As a positive control, Christine used hydrogen peroxide, which obviously makes a lot high production of reactive oxygen species in the macrophages. And if you treat the macrophages with the homogenate, so the images appear very different because now the phase contrast shows the lipid droplets in the macrophages. That's what the images look so different. You can see that there's a significant increase in production of reactive oxygen species, indicating that this lipid accumulation in macrophages makes them express higher levels of ROS. She also looked at she used a cytokine array. This is like a large ELISA. So this is just kind of a Western blot with little dots of ELISAs that are dotted here. And each dot represents a different cytokines. There are about 111 cytokines that we can test in a single strip. And so when she looked at this, she found that there were several pro-inflammatory cytokines that were increased in response to homogeneous treatment, indicating that foamy macrophages are developing a pro-inflammatory response. So now that we know that foamy macrophages are becoming pro-inflammatory and probably contributing to the inflammatory environment of the injury site, we wanted to test or investigate the role of myelin per se in this response. So the injured tissue obviously has a lot of myelin debris, but myelin is not the only source of lipids, right? All cells are made of lipids, and so it could be that there are multiple sources of lipids that are contributing to this. The idea in the field has been that it's all myelin, but as I said before, that idea came about because people treated macrophages in vitro with myelin and concluded it's due to myelin. So that's a gain of function study. So from that, you can only conclude that myelin is sufficient to provide this response. But is it really necessary? And so to address whether myelin is necessary for this response, we took advantage of MVP knockout mice, also called as Shiver mice. So these mice actually lack myelin. And surprisingly, they actually grow into adulthood, but obviously they have some abnormalities. They quote unquote shiver, they shake. They can still walk around fine, which is pretty amazing considering that they have virtually no myelin in their central nervous system. This is a cross section of this mouse stained with Luxol fast blue that typically labels myelin in blue here, but so there's no myelin as you can see here. And so now we're able to use a spinal cord homogenate from these mice and compare it to spinal cord homogenate from het animals. So we use littermate hets to kind of carefully control for genetic background. Het mice have normal myelin. They don't really have any known defects in terms of myelin content and myelination goes. There's no phenotypic deficiencies here. And so if you now treat these macrophages with spinal cord homogenate from the MVP hets and MVP knockouts in a concentration dependent manner, again, as you increase the concentration of the homogenate, the foamy the lipid content in the macrophages increases as you would expect. The macrophages that were treated with the knockout homogenate actually have less lipid accumulation. But this is kind of the case of glass half empty, glass half full. So this certainly does indicate that myelin is a significant contributor to the foamy macrophage formation. But the kind of the glass half full interpretation here is that foamy macrophages can form even without myelin. And so as you can see here, these are certainly, you would certainly consider these foamy in appearance. And so myelin does contribute, but it certainly is not necessary per se. We also observe this in vivo. So now we can take these myelin knockout mice and perform spinal cord injury. And again, the quantifications indicate that there are indeed less foamy macrophages in the knockout mice, but they're not gone. In fact, there's actually quite a bit of them. So it's about 50% reduction in foamy macrophages. But you can interpret this as, yes, myelin is important, but again, it's not necessary. Foamy macrophages can form by phagocytosing this regular cellular debris. So then what's the effect of myelin on cytokine and pro-inflammatory response? This is kind of hot off the press. Christine sent me this data yesterday. So just to kind of sum it up, of the 111 cytokines that we looked at, they remain largely unchanged, whether the macrophages are treated with the spinal cord homogenate from the het or the knockout animal. The two exceptions are IL-1 alpha and MCSF. Interestingly, MCSF was the only cytokine that we observed that was actually increased by the knockout homogenate. And IL-1 alpha was obviously a decrease in the knockout homogenate. So there does seem to be some cytokines that are specific to myelin, and we think that's actually fascinating. And so this is something that we're interested in pursuing. You know, what is it about myelin that is that drives the IL-1 alpha response? By the way, IL-1 alpha is a well-known pro-fibrotic cytokine, and so that kind of ties in to our fibrosis studies. But really surprising thing here is that it doesn't really matter whether the foamy macrophages become or accumulate lipids in response to myelin or without myelin. So the kind of the conclusion from here is that it's really the lipid content rather than a lipid source that's driving the pro-inflammatory response in foamy macrophages. Now going back to the wild type situation. So I told you that there's a whole bunch of cytokines that are increased in response to homogeneous treatment in foamy macrophages. And so this is just a heat map of all the macrophages that are increased here. And so because there's such a large number, we can actually do some pathway analysis, as you see on the right. And so now we can identify kind of certain nodes that we think might be important in these signaling pathways. But another thing we can do is identify terms, signaling pathway terms that are kind of enriched in these overexpressed cytokines. And the three pathways that Christine identified was the RAGE, JAK-STAT, and the PI3K AKT signaling pathways. And to kind of test the possibility or the contribution of these signaling pathways to foamy macrophage formation, she took pharmacological inhibitors of these pathways and treated the foamy macrophages in a dose-dependent manner. And so she used this compound FPSEM1 as a RAGE inhibitor. She used taurin-2 as a PI3 kinase mTOR inhibitor, and she used static as a JAK-STAT inhibitor. And as you can see from the quantification on the right over here, the only inhibitor that led to significant reduction in lipid content was taurin-2. And it happened in a dose-dependent manner, which highly suggests that it's probably not due to some off-target effects. She checked for cell death and things like that, and it wasn't due to cell viability. And so when she tests this now in a separate independent experiment to side-by-side with vehicle and taurin, there's a significant reduction. As you can tell from here, there's a lot less green here than there are in every other panel, right? So there seems to be something about the AKT mTOR pathway that is contributing to foamy macrophage formation. And then this is also associated with a significant reduction in production of reactive oxygen species. So I showed you a similar panel before, but this is now an independent study now comparing the effect of taurin in this assay. Again, taurin has little effect on reactive oxygen species production when macrophages are just in media. It does not have an effect when macrophages are treated with hydrogen peroxide, indicating that this is not kind of some blanket effect on cell response that in response to reactive oxygen species production, but in fact is maybe more specific to the biological processes associated with lipid metabolism. And so taurin-2, as I showed you in the previous panel, reduces lipid content, but it also significantly reduces production of reactive oxygen species. And so now we are pursuing targets of TORRent2 and testing this in an in vivo model to see whether this could be having therapeutic benefits after spinal cord injury. Just to summarize here, so most of the cells that comprise the spinal cord injury site play a protective role in wound healing response. And so now I'll get back to the question that I was asked about 8 years ago from Dr. Levy. What would I predict would happen if you irradiate the injury site? Well, the irradiation I would predict would actually prevent cell proliferation. And in response to that, I think it would actually have a detrimental effect. There may be some beneficial effects, but I think it would be outweighed by the negative response of interfering with the wound healing response. And so if you prevent the astroglial scar from proliferating, if you prevent the microglia from proliferating, I think that would have a negative response in terms of overall recovery. We have been very interested in hematologous macrophages. We think that this is a major modulator of the wound healing response, and we think this is a very attractive therapeutic target because macrophages, don't start to, monocytes come in about a day after injury, after the neutrophils come in. So that gives you a 24-hour window for therapeutic intervention, which I think is much more clinically relevant. And since these are obviously flowing through blood, they can be targeted in a much more clinically relevant way. We don't have to, as opposed to, for example, like microglia, where you have to worry about blood-brain barrier and injecting things directly into the central nervous system. I think macrophages are much more attractive as a therapeutic target. And lastly, macrophages become pro-inflammatory in part by phagocytosis of myelin and other cellular debris that turns them into lipid-laden foam cells. So I'll wrap that up with, again, acknowledging the wonderful people in my lab who have really contributed to this work. And I'll take any questions that you might have.
Thank you very much, Jay, for that fantastic presentation. A lot of cutting-edge research science going on to try to dissect out this extremely complicated problem, very important problem. And thank you very much, and your team for presenting such a lovely presentation today. Are any questions from the group, please?
Yes, Dr. Lee, would you comment on that? Do you plan to look into different macrophage populations such as M1, M2, and their effect on that? That's number one. The second related question is, on the oxidized lipid side, do you have any idea that which class of oxidized lipid is actually the most response eliciting?
Okay, so to answer the first question, yes, we're very interested in macrophage subtypes. And so I didn't show you the data today, but we've been doing single cell sequencing to address this exact question. And we have some very interesting results about different types of subtypes of macrophages that could be contributing. I didn't really show the results today due to time. But yes, we think there are different types of macrophages that are having different functions. Exactly which type is doing what, we actually don't know yet. In terms of M1, M2, the subclusters that we observed in the single cell sequencing data didn't really correspond to the classic definitions of M1, M2 macrophages. We do think that one subtype is probably more inflammatory than the other. So if you want to think of that as M1, M2, I guess you could. but we try to stay away from that nomenclature, the M1 M2 nomenclature in the lab. We just call them A and B for lack of a better nomenclature. And so, yes, so we think there are subtype specific responses. Answer to your second question. Yeah, so we've been wondering whether oxidation of the lipids is really what's driving this process. In part because some of the previous data indicate that CD36, which is a well-known ox-LDL receptor, if you knock that out, there's a reduction in lipid content in the macrophages, and the animal does better. So we thought because of that, oxidized lipids might play a significant role. Christine tried to address this by kind of oxidizing lipids herself and testing this. We actually didn't see a dramatic effect. So we don't, it's not to say it's not important, we just don't have evidence in our lab that indicates that it's oxidation of the lipids that's really driving this process. Our guess is that just bulk endocytosis of lipids has a lot to do with this. And so that's kind of our thought on this. Does that answer your question?
So let me make a comment before I disappear. One is that if you look into many of the pathologies, atherosclerosis, etc., and I'm not talking about macrophages, many times in the CNS, you see two types of cells with respect to the lipid. One that accumulates lipid, and their mitochondria for some reason remains okay. The other phenotype is that they do not accumulate lipid, but the mitochondrial lipid metabolism completely goes into disarray. That has specific connotations. Probably we'll discuss that offline someday. But just wanted to kind of bring to the radar of you and the radar of audience that from the cancer to the others, if you look into that, there are two distinct types. One is in response to certain things, there is a lipid accumulation. The other cells do not. But invariably, the mitochondrial function in one case remains okay. The others do not. So there is some link here.
Yeah, so Christine actually did look at mitochondria. I didn't present the work today, but yes, there is definitely mitochondrial dysfunction in these cells. And so we think that is probably what's responsible for the reactive oxygen species production. But yeah, there's definitely mitochondrial dysfunction in the foamy macrophages.
Thank you.
Great. Other questions, please? Jay, we've been talking about therapeutic hypothermia to look at single cell sequencing for for some of the inflammatory cascades. Hypothermia does a really good job of protecting against barrier dysfunction in terms of the extravasation of macrophages. It also can have a very dramatic effect on the phenotype effect of macrophages, usually pushing them toward a more repetitive. I wonder, it'd be really nice that we've looked at hypothermia, obviously, in spinal cord preclinical and clinical studies with positive effects in both cases so far. It might be nice to see if temperature modification would affect, the response of your foamy macrophages and things like that. So that's something we can talk about offline. I also wanted to ask you, in terms of a more translational picture of what we do with all this information at this time. A lot more research to be done, I understand that. But in a human spinal cord situation, we can fill the cyst with millions of cells. They could be Schwann cells, they could be neuroprogenitor cells, they could be mesenchymal stem cells, things like that, with or without drugs. So is there a step forward in terms of translational, either cell therapy or pharmacological therapy, to actually move this to the clinic in the next several years? I know that's a tough question to ask, but just something that I'm wondering about.
Yeah, I mean, it's a question that a lot of us, certainly our lab, thinks about all the time. How do we apply this basic knowledge and try to move it forward into patients? I showed you the hydrogel data, and so that's something. So like cell transplantation, I think the presence of the cavity, I think it was just people kind of shrug their shoulders and say, well, there's cavity there, and we don't really know what it does, and it's probably not good. But And so you try to fill it with cells, and a lot of cells die, and obviously, and so it's a bit hard. But I think with the hydrogels data that I showed you actually presents a really interesting opportunity that where we can now use biomaterials to not just to fill the void, right, but to actually drive a biological process that would promote tissue repair. And so obviously, if you had a magic, not bullet, but a magic gel or biomaterial that would do all this, that'd be great. But the nice thing about the hydrogels is that you can combine it with other therapeutics, which I think is probably the likely way to go. So for example, I just showed you the data on taurin, and the thing about taurin is, it's an mTOR PI3K kinase inhibitor, which we know is very important for neuronal regeneration and axon growth. So I'm certainly not advocating inhibiting mTOR and PI3 kinase in the entire body after spinal cord injury. So now we need to give this in a more targeted manner. And so I think that's really one of the keys here. How do we deliver these therapeutics in a much more cell type specific manner? In addition to the hydrogel, we've been toying around with nanoparticles, specifically targeting macrophages. And the nanoparticle that we've been actually using for a long time, but really kind of, we didn't consider is considered as a therapy, is all the liposomes. So the liposomes, is the most widely used nanoparticle in the clinic. It's probably the most successful example of a drug delivery vehicle that's being used in the clinic, more so in the cancer field. But certainly, I think there's no reason we can't use it in neurological disorders. And the nice thing about nanoparticles, at least in our sense, is that whereas everyone else considers the nanoparticle uptake by macrophages to be kind of a confound in their study, to us, this is an actual advantage. And so we think that using these cell type specific nanoparticles to target macrophages would be a therapeutic approach that I think would be, that we're considering for the future.